It's 11 box actually. Just this case was done on 26 to 28 November when I was doing a complex PCI workshop in Faridabad, where there is 17 cardiologists was there. It was a young male with a chronic stable angina. Patient already had undergone stenting to circumflex LAD and RCA early. Came with angina for the last 2 years. He's a drug defaulter and a smoker. I'll go to the case. Patient had a complete occluded stenting of the LAD is totally occluded. There is a disease on the LMCA, minimal disease on the RCA. You can see a lot of collaterals. When the catheter was just put itself, the BP, there is a BP fall. You can see that I took over. You can see a small, tiny connections from the ostial LAD, but there is an angulation there. We decided to take an antegrade approach in this case. It's a 36 minutes, I have to finish by 25 minutes. There is an order given by Anil. So I'm just trying to push in between the slides. So I'm just trying to take a microcatheter with a filter FC to enter, making 2 curves inside. My ultimate aim is to reach there. Once I reach there, take an XTR wire. That is my plan. You can see the wire is reaching, wire already bended. And the bend was almost made by 2 bends with an angulation. The microcatheter is kept in the ostium, but actually the catheter was, when the catheter is going deep inside, the BP fall is coming. So that is a bend is there, but my wire is actually going into the ramus as well as the circumflex. If you look at the angiogram carefully, you can see that the circumflex also diseased and ramus is free of disease. But there is a distal bifurcation LMCS, and you can see the circ is also diseased. The osteoproximal part of the RCA is also diseased. There are 18 cardiologists watching. I'm trying to put the wire, but the wire is actually bending, it is not entering there. I just wanted to take the wire there. Or there is another options are there. You can take a dual lumen catheter, keeping the catheter there and take the wire inside. I tried. Then there is a BP fall. I put the catheter back and keeping the wire there. And I was not aware that where the BP fall is coming out. Trying, but this wire is not going into the LAD, which I am very sure about it. But I was sure that there is a lot of collaterals coming from the RCA. So immediately I kept the microcatheter and RCA filter FC wire into the ramus, and I took a filter FC wire with the fine cross here to the RCA. There are multiple collaterals. You can see that actually there is, when we are giving an injection, you can see the distal most 3 collaterals are very good. These are the collaterals. So I just made 3 collaterals. 3 collaterals are very good. But I just wanted to go to the 3rd collateral, but the 2nd collateral was actually easy to go inside, and the 1st collateral is tough to reach there. So that is the story there. And just come back to the case again. So the distal most part, that is actually looking like a entry point was very good in the distal part. Actually, it is not the part, it is actually the next part. No, yes. Once the wire enters there, there is a bend there, but the wire goes easily up. But actually I did not shift over to the cyan black. Usually my trial is actually end to there and then switch over to the cyan black, but the filter FC itself is gone up. Once the wire has gone up, you can see there is a bend created there. Once the bend created, especially with the stent inside the LED, from that septal channel to enter to the LED was tough. The microcatheter is not moving up. So when the microcatheter is not moving up, there is a chance that you have to take the wire into the LED and to get into the small branches. So I tried to take the wire and I have taken the wire into the another septal channel and trying to push the wire. Not possible. So earlier I thought it is very simple, but the wire I kept into the another septal channel, but even then the wire is not going down. So the next option is actually, you have to create a channel dilatation, keeping the wire there, and take a balloon, inflate, and actually create a, then you remove the microcatheter via balloon trapping, and take a balloon 1 into 6 millimeter, which was not available there, 1.25 into 10 millimeter balloon, which was not available there. Not reaching, but I am just trying to take the wire as deep as possible inside the stent, but this projection will help me to see that my wire is inside the stent. Now I am looking at the other angle. So this is the vessel I went inside now, but I am just looking, there is a septal channel coming up here and it is going up there. So this is another channel I am looking at. Now I remove that wire because I know that if that wire is going, I will not be easy. So the wire going up. Once this wire going up, again it went inside. Again, different channels I am trying. It's called septal surfing to reach into some vessel. But you can see that wire I have taken as deep as possible so that I was thinking that I can take the microcatheter up. But not possible. So what I did is I took the wire into the diagonal artery down so that my taking the microcatheter will be easy. So the microcatheter going up, the microcatheter gone down because I have taken the wire into the diagonal, then I end into the septal artery. With that, the microcatheter going up. You can see the microcatheter, that is the middle Parker, it is going up. Once the microcatheter going up into the stent margin, it cannot cross into the stent. So where you can do that, you keep the wire there, take the microcatheter out, you can take a 1 into 6 millimeter balloon dilatation.
What is the microcatheter? Fine cross?
Fine cross. Only fine cross in both sides. One fine cross is already sitting on the left system. It's actually, now the wire is there. So this wire cannot go. This is actually a filter FC wire used in the first one. So I have to keep the wire there and I have to take the wire out. I'm taking the wire out. Now it is a dia second wire. Once the dia second wire, the wire I have to take into the LED, proximal LED, not into the septal, but it is not going down. So I'm making a bend there. I'm actually making a bend to go into the other side, but there is an advantage that the wire can go inside because you are seeing this one. Now I'm taking a bend. You can see this bend is creating that distal part of the wire is actually having no support. Now the wire is going inside and I wanted to take the wire as distal as proximal as possible into the a lady so that I can take the microcatheter out. So once the microcatheter is not up, then I cannot take an RG3 wire out. That is the problem.
The retrograde wire looks a bit on the edge of the vessel, isn't it?
Correct. Retrograde wire is actually taken, this is actually making a bend there and then not going inside properly. So this is actually in our Gaia second wire. See, I am actually showing the problems I created. I wanted to show this case actually, it was created a lot of problems. So the microcatheter is actually not going up. So now wires went as distal as possible. So, but now microcatheter is not going up. So the next step is actually, this is an important step. I am taking a balloon trapping here, keeping the microcatheter there. Microcatheter is out, and with a balloon trap, I just wanted to take the microcatheter out. Once the microcatheter out, I was thinking that I will do a septal channel dilatation. So this is actually the trapping, that is why there is no BP on the side. So after that, I just wanted to take a balloon. I asked for a balloon. The balloon was actually, I actually switched off the sound because I am just abusing people. So I don't want to show the abuse here. So I just asked for a 1 into 6 millimeter. It was not there. I asked 1.25 into 6. There is no 1.2510 is not there. They have given me a 1.2510, which is actually, I asked the Ikasushi 1 into 6. They gave me 1.5. So I could not take it. So the problem here I'm creating, now this wire is actually, once I taken a balloon of 1.25 into 10 balloon there, now the microcatheter, the wire came out. Once the wire came out, this is a Gaia second wire. You should not manipulate too much Gaia second wire inside the septal channel. That is actually an important thing. But when you are in a workshop with limited materials given to me, so I should do that. So some of the workshops I do with Oaks wire also CTOs. So now this is actually, now the wire came down. The wire came down, but usually what you should do, keep the microcatheter there, take the wire out, and this wire should not be manipulated. I am manipulating the same wire. It's a mistake. And I just wanted to show the problems I created.
Yeah. Interesting.
Interesting means these are the things we do always,
Yeah.
create problems. See, now this is actually, in between I am going because I have given an order that I should finish in that time, So this wire is manipulating inside the septal channel. That is actually Gaia second wire. You should never do that. So this time, patient is actually having some BP problem. They were telling there is a BP issue, but I was thinking I am in the true wire and then going inside. So I'm manipulating there. Now I decided, no, I want to check what is happening. Now I'll see what happened. Definitely it would have created a perforation, right? That is what I also thought. So now I am going to check it. Actually my catheter in the right system also, I am just pushing back and given an injection. Waiting with patience. See, I created a perforation. This also I am making a big noise here. I wanted to see that this is the perforation I created. So the next step is actually you can close the perforation by keeping the wire there. But I decided that is in the septal channel. Let it be like that. I taken the Gaia second wire again back, and I just wanted to find out any other channel available or not. I just rewind and the system and then seeing how is it possible. So now I take the wire out. Now again I am coming back. I have seen a channel that's a distal most channel, so that you can see the collection of the blood there. So I understood that I am even now okay, but there is no bleeding. So this is actually the angle which is actually I was looking earlier. So there is an angle there, and they have to bend there and then go inside. So that is what is my aim now. Luckily, this time it is easily gone inside. See, actually you should go to the best channel available in the first instance. Now, I wanted to make that wire going upward. That means towards the proximal LED. Now that's actually the wrong channel. I just wanted to come down now. I understood I am not in the right place by checking. You can see that the channel I wanted to come down is into that side, that channel. Now I actually went into the right channel. Once I am into the right channel, I take the wire immediately into the proximal LED. Here I am in a stronger position. So my wire is also taken in the right path where I could
What
take.
wire is this?
This is actually the same cyan black.
Filter FC.
No, now it is cyan black.
Cyan
Changed.
black.
Yeah. Now with the cyan black, I could go inside. Earlier filter FC was going easily inside, so I just kept the wire there. You can take any wire. The ideal wires are cyan black, and Suho 3 are the wires. But these are all grade 1 channels, so easy channels to go inside. So I did not bother about that. Now the microcatheter is going up. Once the microcatheter going up, it is gone and pierced into the LED. So once it is in the LED, I took the wire out and I have taken the Gaia second wire. Now the Gaia second wire, I was thinking I will be in the lumen. Now I have to check that whether I am in the proximal part of the LED or not. Now I go to the different angles to see that. So now when you take the wire here, you are actually having an angle there. Once the wire enters, there are two ways you can do. You can take the wire into the circumflex artery or into the ramus artery, or you just take it. So now the wire is out of the vessel. So in the proximal most part, wire is in the out of the vessel. And you cannot do a reverse cut here because your wire will not enter there. So your only thing is you have to manipulate. The osteoproximal LED comes from the retrograde. If you have no access, there is other way. You can keep a wire into the circumflex or into the ramus and do an IVUS to understand that whether wire enters into the true lumen there or not. See, the wire is actually out of the vessel. Once the wire is out of the vessel, here, now you have done a lot of manipulation. It is, even though it is 36 minutes shown, it is a 2.5 hours case.
You didn't want a wire in the circ, a wire in the circ or ramus to...
Already wire was there. The wire has gone out. Actually, the microcatheter is still sitting there in the other wire.
Okay, that's not
See, these are all, wire will be there. No wire will come. Now actually I am seeing that there is a BP fall there. Patient is actually having a BP fall, chest pain. I was actually in trouble. So I don't want to lose the circumflex and ramus at any point of this case, because this case actually, when you lose the circumflex and ramus, patient will die on the table. And there are 18 cardiologists watching me in that place. That is another tension, you know. Now the wire is inside. I just wanted to take wire into the ramus also, then I am actually crossed the CTU and then went inside. So the wire is there, this LED. Now I am taking a wire. I just wanted to take a wire immediately to the ramus because I have to preserve the left system perfect, intact. So I just take the wire ramus, but I know that I heard that there is a BP fall. So I have to check that whether ramus is created a problem, circumflex. Circumflex is already having a mild disease. So now there is actually BP is less seen there in one system. Now it is okay looking. This is actually the previous first angiogram. Now there is a BP. No, these are all the previous rewinding and seeing exactly what is the situation. Now the microcatheter is there in the retrograde system, and you are seeing, now we are going to give an injection and see exactly what happened there. This is again, I have taken a cyan black wire now. So because cyan black, actually I can manipulate the distal part, not like the Gaia second or Gaia third. Not entering inside. The osteoproximal part of the LED is actually very tight. Now you can see there is a problem inside the circumflex. Circumflex flow is very, very less, and there is a lesion there. So now immediately if I see, you can see there is a flow, there is a BP fall is because of the circumflex flow. You can put an IABP, ECMO, Imbella, these are all without those things. I just wanted to show a chip case without all these things. You can see the microcatheter there inside the left system. Now I'm taking a wire very fast. I just wanted to take the wire into the circumflex system. I have to preserve both the wire, both the vessels perfectly. See, that is a problem. When you want, the wire will not go in the right place. Now I'm making it bent. The wire gone that much, the wire has gone down. So the two wires, one in the circumflex, one in the ramus. Now I just wanted to take the LED system wire. Because two things are there. Now I just wanted to have the flow, BP should come up. I just wanted to take a balloon. When I asked the balloon, they gave me 1.5 millimeter or 2.5 millimeter balloon. See, I'm keeping the catheter just outside.
This time when you brought the retrograde wire, wouldn't it have been better
Almost there.
Wouldn't
See,
it
I'm
have-
just actually, my problem is actually, there is a BP fault. Now the retrograde wire is on the left system itself. I went into the LMCA. But the problem, there is a BP fault, you can see that. That is why I just wanted to dilate the circumflex. Moreover, this dilatation will help me to I'm creating reverse cut there. So I just understand that the virus, this balloon inflation also will help me. But there is a BP fault, the patient is actually struggling. So I'm firing people back. You can look at my face. So BP dilatation coming up, 2.5 millimeter balloon. I asked, they've given me a 2.5, the value is not going. Then I took a 1.5, then 1 millimeter balloon, this actually dilated. Once you dilate, there are two things. We will get a flow back, a plus, as well as we can actually easily, with this one, your wire will go inside. So I'm trying in between. Once the balloon dilatation going on, at the same time, I'm trying my wire to enter into the LMC system. That is actually the left system. So I'm deflating itself, I wanted to take the wire inside. Now I am actually out of the vessel, I am sure about, I am actually crossed the LMCA. Now I just wanted to take the catheter there. I'm little making myself cool. Now I have to take the catheter into the left system because the catheter is half out. So I'm manipulating the catheter into the left system. See, now I'm in the left system. I just wanted to withdraw the catheter. My wire has gone inside. Once the wire has gone inside, now I have to take the microcatheter inside. Now, microcatheter gone inside. Now the trapping the balloon. I'll go fast here. This wire is actually going out. I've taken an RG3 wire there. Balloon dilatation. Already I have 3 wires. LED system wire is already there. But the story does not stop here. Actually, I'm showing how the wire is taken out. The wire is taken out. Okay. Through this needle, it will come out. It came out. So the left system, the wire came out to the left system itself. And there are 3 wires now in the left system. The antegrade 2 wires on the ramus as well as the circumflex, and there is a retrograde wire coming out. Now I have to dilate then I understood even a 1.2 millimeter balloon is difficult to go, and they don't have a good balloon system, and then whatever the balloon is given, only I am trying to do it. Anil Kaiman sat there. I have time, huh? So when I am seeing, I should finish fast, Now the balloon dilatation comes. So now the next thing is actually you have to take the microcatheter down into the septal channel and then do a dilatation. Now the balloon is coming out. I am just dilating. So difficult, that osteoproximal part. Already patient has 2 stents in the left LAD, 1 stent in the circumflex, 1 stent in the RCA. Dilatation. Balloon dilatation is happening. Actually, you should understand that it's 1.5 hours to 2 hours gone. There are problems with these cases in all the integrated system cases. You can develop thrombus. So you can see that there is hands on the chest. That means patient is actually getting to cardiac massage. BP fall. But in the meantime, you have to finish one stent into the circumflex is important. See, there is a flow problem. There is a dissection created with the thrombus. We have given bolus eptifibatide, balloon dilatation. Without balloon dilatation and a proper preparation of the lesion, you can't do anything, because I just wanted to do a mini crush technique there.
So the circumflex occlusion was
Is the most
thrombotic.
important problem.
Was thrombotic.
I actually understand. Actually, thrombus with dissection. We don't know. There is a dissection also. So I just presume that there is dissection plus thrombus. So we have given eptifibatide. The cycle is you can see that the heart is moving very, very faintly. But at the same time, the wire came out. Now the wire again going into that. I just wanted to take the wire not into the ramus, into the LED now, so that I can take the left system, right system out and then start the procedures. But the wire is not going. Then you just go ahead again with the RG3 wire. Now I am checking. No flow. Time is not finished. 3 more minutes actually, then it will be 20 minutes only. I am looking at the time. I have the time with me. Otherwise, I'll stop it and then you tell that what to. Now I put a 23 millimeter stent into the circumflex because I know that that is a life-saving vessel. I just put a stent. Just put a balloon dilatation. Then recross the wire. Wire is taken out. There are a lot of things happening in the backside. You can see flow is actually very less, but I just understood that the circumflex system is now okay. Now there is a dissection created in that. I have to dilate the total part and the wire is taken out. I'm making it as fast as possible. Balloon dilatation. Because there is no cutting balloon, so I have to prepare the lesion very well, because especially in not doing an imaging, already 2 hours, 20 minutes for the patient. It's actually a 3.5 into 38 stent dilatation. Once I dilated, then I have taken out. Cardiac massage going on. So now I have to recross the wire into the circumflex. On massage, there is a flow down. Then I just given again eptifibatide. Give me 3 more minutes. Huh?
Any
Cardiac
ACT was checked in between?
Yeah, actually, the patient BP is not there. What ECG, man? What
No,
BP is
not
there.
ECG. ACT.
ACT is, actually, I don't know what I am asking. I just do, you give me eptifibatide, you give me balloon. See, I'm just, these are all people's hand. I'm firing, manipulating. There is no heart movement is there. I don't know the operator standing behind that fellow, that behind, the third one. He is actually his own patient. He was crying because he has to talk with the relatives, you know. So I just go to everywhere and do cases, you know. Ultimately, these people has to tell the relatives. Now I have to take the wire down because I cannot just leave a bifurcation standing without a wire. So on cardiac massage, I pass the wire into the circumflex. He is not allowing, that is why I would have shown that. So I just pass the wire down. During cardiac massage, this fellow is actually massaging on my hand also. So I just wanted to pass the wire down. So in between shock. And finally I pass the wire. Once the wire gone down, I'm just asking a balloon to come down. Once the wire gone down, I can manipulate anything, because actually I just wanted to have 1 second allow me to pass the wire, because there is massage going on. No, it's 20. This fellow initially told me 40 minutes, then told 30 minutes, now it is 20 minutes. Not for me, as for the procedure, just the wire gone down. Once the wire gone down, I have to balloon dilate. Cardiac massage going on, 2 balloons and 3 millimeter and 3.5 on the either side and 4.5 millimeter balloon on the LMCA. Now balloon gone, 1.5. This is not the fastest speed, it's only the, see, you can see in between heart is moving. Asystole is happening, VT is happening, BP fall is not there, the balloon is coming down. I don't know. That I am not an electrophysiologist and I cannot identify balloon dilatation there. So balloon is dilated. So I just gone. During cardiac massage I do. Now the flow coming down with the left system. LED is actually not flow zone, balloon dilatation. I just wanted to dilate throughout the balloon. Now it is kissing inflation. Now I just wanted to pass the wire down. Now a balloon dilated. So now I will be taking a wire. Now this is actually an important step. I have taken the microcatheter up. Through the microcatheter, this retrograde wire, actually I removed. I kept the wire there. This actually manipulated wire is there. Through the retrograde RG3 wire, I took the microcatheter down into the antegrade system. So keeping the microcatheter there, you can see the microcatheter. I removed the RG3
The
wire.
circumflex stent did not come into left main.
No. Circumflex actually into the LMCA 2 millimeter strut and balloon dilator. And kissing is done, even the pot done. Now what I did is actually the RG3 wire. Through the RG3 wire, I taken a microcatheter. Through the microcatheter, I passed the wire down. You can see, this is actually the RG3 wire. I took the right system because even the right RCA having an osteoproximal disease, the wire come down. Once the wire come down, now the patient's some BP is coming up. Now I have to dilate that part. Now the flow is not there. I give a absciximab or eptifibatate, whatever is available. But I was now cool. Personally, I was cool. Only that fellow is tense, you know. See that face? Now I balloon dilated. You can see that. Just look at that fellow that's standing on the with the. He will. You just look at his face. You will understand whether I am doing right or not. He will be happy means that fellow, that last fellow, standing there. That fellow's face will tell you that what I am doing right or not. So the wire is coming down. So I just wanted to take the wire because these stents and all distally I could not see. I dilate with a 2.3 millimeter balloon throughout. And the junction, I just wanted to take a balloon. Now I'll just reasonably, now I got a flow down. Now I thought that I'll just take the wire as distal as possible because this wire I changed. Balloon dilated, so 1.5 millimeter with the junction I dilated. I got a flow down. So the patient is, you can see the face of, see the smile. That indicates everything was perfect and he was very happy and I showed. Don't ask me anything further.
No,
I just stopped the case
Prathap,
here.
we stopped
And
looking at the angiogram long back. We are
I
still
was
watching that guy
actually,
only.
I just wanted to, I understood that. But I'm just telling that the point is basically the microcatheter cannot be advanced. What are the things to be done? Take the wire into the side branch or the distal vessel.
Usually retrograde we take Corsair or Corsair Pro or
No, it is not like that. I always think the fine cross is a very good one. A turnpike LP is a very good microcatheter. And a Caravel is also the 3 microcatheter. Corsair Pro XS is good, not Corsair. Corsair is not a good one.
retrograde central channel also you take
No, I take fine cross or Caravel or Corsair Pro SS, not the other earlier Corsair. So what I am telling that take the wire into the side branch of distal vessel, change the microcatheter, Second is actually dilate the septal channel with small balloons. You can have an anchor balloon technique or attempt another septal channel or try another. And no flow, what are the causes? Thrombus and combination. The problems in this case, number one, it is an ostial CTO. Second, angulation of the septal channel. Third, difficulty of wire entry to the LAD from septal channel due to stent in the LAD. Four, attempting the septal channel entry by Gaia wire, not to be done at all. Five, minimal lesion in the circumflex with the dissection of thrombus. Six, not having a mechanical circulatory support. That is what actually Rustam is wanted to tell. I don't use it. Ostial lesion of LMC and RCA may be angiographically not significant. Not doing an imaging, not having small balloons and cutting balloon. Take home message, MCS could have helped this to do this case without tension, number one. Perseverance was the key to success. In Indian financial setting, most of the time, success of the complex case are due to operator skill rather than equipment. Imaging not done in this case due to time taken for procedure, not due to the non-availability. And it was a must in this case to understand the reason for the ISR. Even in this case, it was a teamwork. This case was done during a cardiac intervention workshop. And thank you very much.
Very nice case, Dr. Prathap. My only message would be if you have or in audience, if there is a Boston Scientific IVUS and you have 7 French antigrade, and the easiest way to do this case would be just IVUS guided in real-time cap puncture, especially if you had microchannel, and then further down stents would help you. Going through septals, for me, it's usually dedicated microcatheters, like we mentioned Turnpike LP that you like, I like it too, and Corsair Pro, for example. Now, another important point, when you go antegrade through stented LAD through septals, you dilate sometimes and keep going. A bit hesitant to go retrograde through this stent because sometimes microcatheter can snap and trap the whole thing. Sometimes when you wire it through the stent towards left main, positioning IVUS on the circumflex wire can also tell you in real time how you're traveling with retrograde wire. Keeping wire as a safety wire in circumflex also very important for people who learn interventions. In this case, safety wire is very important to prevent problem and have an access. And that's probably the main comments. Another important thing, nowadays, very rarely I do actually externalization with dedicated wires. In this case, once your retrograde wire in the curve of EB or XB, it just, you have antegrade.
No, I externalized with the RG3 wire only.
Yes, but I do this very rarely nowadays. Once your retrograde wire in the curve of ABU or XB,
or you can
or
actually do a rendo phenomenon or a tip-in.
Tip-in, yeah, tip-in works so
But
perfectly.
this actually, once the RG3 wire was inside, then you are in a very safe position rather than tip-in. You may not be able to take the wire that time.
No, but
easily.
the technique that 90% of retrograde cases I do tip-in is just so predictable, it's so easy. Immediately your case converts to antegrade. You don't worry about squeezing the heart, about causing cheese cutting effect, etc. All the things that comes from is externalization wire. I know Japanese always externalized, but tip-in just makes case easier. Thank you.
Correct.
Thank you.
But actually the entry of the LED ostium, even with IVUS here, will be difficult because of the angulated entry. And another point is actually you have to take a cruciate or a double lumen catheter to take the wire inside. But the angle was actually making me so troubled to enter inside.
Yeah, thank you, Dr. Prathap.